Good evening, everyone. Thank you so much for joining us again this evening for another one of our monthly webinars coming from the Department of Pediatrics. Tonight, we're talking all about PCOS and other menstrual disorders. We're going to give people a couple of minutes to join before I introduce the amazing panel I have with me this evening. A couple of reminders while we give people a second to join. We're on social media. You can follow us at Kids at Columbia. There are updates that we put on there about happenings around Columbia Children's Health. We also share expertise from our amazing pediatricians. So find us. We also have an amazing children's health newsletter. So you can sign up for that and get it every month as well. We will send you the link to sign up in the recap from this webinar. And if you haven't yet signed up for the 11th annual pediatric specialty updates for the general practitioner, the annual CME put together by the Department of Pediatrics, the list of topics and experts this year is amazing. It is all virtual, and the sessions are available for months after the actual meeting if you're not able to join in real time. With that, let me introduce our amazing panelists this evening. And I guess I'll introduce myself if this is the first time that you're joining us. I'm Dr. Edith Rackow. I am a pediatrician here at Columbia. I'm in primary care. Tonight we have with us Dr. Dara Steinberg, who is a pediatric psychologist, Dr. Dominder Kaur, who is a pediatric hematologist, and Dr. Beth Rackow, who is a pediatric and adolescent gynecologist. We're really so happy to have you all with us tonight. As a reminder, we do have a quick disclaimer that the content of this webinar, and I clicked away from it. I'll put it back up for 2 seconds. The content of this webinar is provided for general information only and should not be relied on as a substitute for any professional medical advice or treatment. And the views that are shared on this webinar solely reflect the expertise and experience of me, your host, and our amazing guest this evening. So let's get started. I'm going to stop sharing. Tonight, the focus is on PCOS and other menstrual disorders. For everyone who's joining, please send us your questions as we talk through this evening. If it pertains to what we're talking about right that second, we'll try to weave it into the conversation. Otherwise, we will have time at the end for questions. So just drop your questions in the chat as we're going. So I'm going to go to you, Beth, first. We're talking about menstrual disorders. I think there is such a wide variation of what's normal in the menstrual cycle that let's just start by grounding us on what is normal before we start talking about what's abnormal.
Great topic. Well, first of all, thank you for having me as part of this exciting panel. So thinking about menstruation and menstrual disorders is basically my day in and day out. It's important to have a really strong concept of normal to understand abnormal. So when we think about menstruation, we think that typical average age of menarche in this country is about 12 and a half, with a range of about 10 to 14. Most girls within the first menstrual year, their average menstrual length, and we count from day one of one cycle to day one of the next, is about 32 days. But that range is typically from about a 21-day cycle to a 45-day cycle, which is considered normal. And while we all may see girls who go 3+ months without a period, it's important to know that those girls are well beyond the 98th percentile of what we see for normal. So these patterns are like we expect irregularity for at least the first year or two after menstruation begins. However, irregular menses can continue for even several years, and many girls have not established regular ovulatory menstrual cycles until several years after menarche, in fact, up to 8 years even for some individuals. So there's a wide range of normal out there.
Yeah, and I so appreciate you framing it that way. Beth, up to 8 years. I don't think I realized that. As a primary care pediatrician, I sort of counsel to, 1 to 2, sometimes 3, but up to 8 years. Of course, I'm sure you're thinking about other things as the years go by, but that is very, very interesting to know. Now we have to talk about what happens when things go wrong, and several things can go wrong. So I'm going to turn to you, Dominder, as our hematologist on this panel. Starting with bleeding, right? Which is a big, big category. But when it comes to bleeding, what are the most common menstrual disorders relating to bleeding abnormalities that you see? You're muted, Dominder. Sorry.
And adding to what Beth was just indicating, the normal process of going through menstrual development goes through anovulatory cycles. So you can see irregular and heavy bleeding just because of that. But the time that we start to worry, and we would like for people to worry a little bit more, are occasions when there is what we call as increased volume loss during cycles. And in that, I would like to sort of try and indicate what seems to be acceptable degree of bleeding. So if you're having cycles every 20 to 28 days, cycles that are indicating bleeding lasting less than 7 days, and then we can talk a little bit more about what is heavy bleeding versus less heavy bleeding separately. But all in all, when we see heavier bleeding, it's possible that there might be an underlying coagulation disturbance, or what we call as bleeding tendency, that could lead to menstrual irregularities. We understand that irregular bleeding can be seen in as many as 53 per 1,000 women, while bleeding disorders, commonest one being von Willebrand disease, which is deficiency of a particular coagulation factor called as the von Willebrand factor, is as prevalent as 1% of the population. We don't diagnose it in 1% of the population because the male patients don't often have symptoms, whereas the female patients get diagnosed about a third of the time with presentation with menstrual irregularities. So that's one big one to keep in mind. It's a lot more prevalent than we think about. When we think about bleeding disorders, one may think about hemophilias or like factor deficiencies, but von Willebrand is the common one to consider and presents often with menstrual irregularities. The second thing to know about is platelet dysfunction. And this could be acquired platelet dysfunction versus congenital or inherited platelet dysfunction. It could be platelet abnormalities in terms of numbers as well as functions. To backtrack a little bit, platelets are our blood cells that help stop bleeding. When we have fewer platelets or dysfunctional platelets, that stopping of the bleeding does not take place very well. And if you have few platelets because you have another diagnosis like immune thrombocytopenia, or because you have been taking a lot of pain medications during cycles, which are painful, it can lead to an acquired platelet dysfunction as well that can worsen the bleeding. And then beyond that, hemophilia and what we call as rarer factor deficiencies, which are honestly, less and less frequent. For example, hemophilia, we see 1 in 5,000 patients, hemophilia A, that is called as factor VIII deficiency. It's another one of the coagulation factors that could be slightly lesser in the body. And it could be as rare as 1 in a million for the other rarer factors being fibrinogen deficiency or factor V deficiency. So really, it's a broad spectrum, but the commonest ones to think about are von Willebrand disease and platelet dysfunctions.
Yeah. And this is exactly why we invited you, and we're so lucky that you made yourself available this evening. Because as the
Happy to
hematologist
be
on the
here.
panel, you're thinking through all of these things, right? So for the primary care pediatricians that are joining today, the general providers that are joining today, how do you start to think through these diagnostic considerations? Like, how do you start to figure out, is this a variation of normal? Is this a sign of a menstrual disorder itself? Is this a bleeding disorder? How do you sort of start to really think through that? Is it based on your history, the physical that you're taking? Just help us sort of begin to think through those things as they may come up in the general office.
So honestly, exactly like you said, a lot of this is history based. And it would probably not even be initial presentation. It would be with the recognition that a lot of young women starting with menarche will go through some irregularities. So allowing some period to consider that. I also agree, I hadn't thought of it as long as about 8 years, but first to second year, some irregularity we recognize could just come with maturation of the hormonal system. But discussing what seems to be heavy bleeding in terms of history is how we get to identifying what is abnormal. And I'll go back to what I was mentioning. Anytime bleeding lasting more than 7 days, occurring more frequently than every 20 to 28 days. Sometimes there could be some bleeding in the middle of the cycle called as middle schmerz. So you have to sort of exclude that consideration, but bleeding happening more than 2 cycles a month at the beginning or end of the month, girls having description of blood loss that goes on to describe needing to change pads every 1 to 2 hours, needing to change pads through the night, pads or tampons, needing to have double coverage or having accidents despite having adequate coverage, having a gushing feeling frequently when they're walking around or getting up from seated position. It can happen in the getting up from seated position, but if it's a frequent thing while being active, that sort of indicates slightly heavier bleeding, passing of clots that are larger than the size of a quarter coin are generally factors that describe heavier than normal bleeding. And one good tool to be objective about this is using what we call as pictorial or menstrual pictograms or pictorial assessments of bleeding. And I would like to have you share that image if possible, because that's something that even trained hematologists don't go through, but this is a very easily available tool that does the identification of what is heavy bleeding as opposed to what could be normal bleeding, than even discussing all the 5 to 6 things that I just mentioned. If you are seeing a patient who has a lot of the bottom line, the bottom section in this, more than 1 to 2 days of their cycle, you're probably seeing heavy bleeding. And what we define as heavy bleeding is more than 80 ml of blood loss per cycle. In addition, I would like to point out that if you are seeing a female who has become significantly iron deficient soon after menarche or has needed consideration of repeated iron supplementation or needing IV iron or even needing blood transfusion, that's when you should be thinking, where is the blood going? Because we typically don't see this happen in the male adolescents. It's only the female adolescents that tend to go through this sort of path. So this is called a menstrual pictogram. It is easily available. There are many versions of it that are easily available online, but we can make links of these available if need be. This particular one is called a Wyatt, WYATT. MATT menstrual pictogram. And then in addition, there's also importance to family history as well as sort of bleeding history, what we call as identifying a bleeding score. We go through what other type of bleedings the patients have experienced, bleeding while brushing teeth, frequent nosebleeds, any other type of bleeding like easy bruising. If there are any yes answers to those, we are more concerned of a possible underlying bleeding disorder than just attributing it to anovulatory bleeding. And it is in these patients that I would at least do a coagulation screen and look at the von Willebrand factors and platelet function.
So that is exactly what I was going to ask you next. And a question came in the chat about where do we access this picture? And it's called a menstrual pictogram, correct, Dominder?
Correct. Yes.
We can send it in the recap from this webinar. But super helpful to use. I have to tell you now something that I have used regularly in practice, but that I will definitely consider as a tool now because it's so visual and so great. Again, for the primary care clinicians that are on the call tonight, when you are considering one of these disorders, what's the initial sort of workup that you would recommend before? Listen, I'm referring to you, Dominder, but as a primary care clinician, right? Like if my suspicion is high, for one of the disorders that you mentioned, I'm referring to you. But what is the recommended initial workup that you would do?
So providers can start with a good detailed patient history as well as family history. That guides our scoring for assessing for bleeding disorders. And in terms of lab testing, a CBC, looking at the platelet numbers, a complete blood count that is, and a coagulation screen, which basically would include a prothrombin time, an ABTT, and partial thromboplastin time, and a fibrinogen level. If you have a reliable lab that does von Willebrand testing and knows to process von Willebrand testing appropriately, and I say that specifically because if there are tubes that are collected but allowed to sit for a few hours, like 6 to 8 hours before things are run, you will identify many false positives. So I would suggest doing this with that caveat that you want to use a quick and reliable lab that can do the von Willebrand testing for you. But those are the initial tests that I would start with, and also getting a history about if there is medication use that could be affecting platelets. And the common ones really are NSAIDs, ibuprofen-containing medications, or anti-seizure, as well as some tricyclic antidepressants and SSRI. So those medications you want to get a good history about as well.
Yeah, super helpful. I have one more question for you, and then we'll move on. And also, by the way, thank you to everyone who's sending your questions right now. We will get to them. I am seeing them. We will get to them. I promise. Dominder, tell us about the clinic that you are leading for women's health and bleeding disorders. Tell us about it.
So the clinic is basically a young women's and adolescent hematology clinic. The reason why this effort was started is because menstrual disorders, heavy menstrual bleeding, as well as bleeding disorders that lead to further hematology issues are significantly underdiagnosed in women. About 40% of adolescent females are anemic, and we haven't got to diagnosing those many patients. About a third of women who get diagnosed with bleeding disorders eventually in life have gone through heavy menstrual bleeding, and it could be much later in life that they actually get diagnosed with it. Additionally, there needs to be an easier way, easier path to diagnosing these patients. So that's where this effort came about. We are a combined clinic wherein adolescent medicine and hematology has partnered to care for patients who might be undergoing heavy menstrual bleeding or have any other underlying issues and require sort of some supportive care during menstrual abnormalities. For example, patients who are on blood thinners and antithrombotic therapies, or are considering gender affirming therapies and seeing some complications associated with that. So it is available within the Columbia system. You are free to refer through the hematology clinic or adolescent hematology clinic, and we're also available just for some questions if any come up.
Amazing. And then maybe what we'll do is we'll send a link when we send a recap from this webinar if people are interested and have patients that they'd like to refer. Beth, I want to go to you next again. You see many teenage and young adult women. What are some risk factors, in addition to the family history that Dominder talked about, when you are seeing these women regularly that make you go, this could lead to a problem, or this puts this child, this patient, this teenager at higher risk for a menstrual disorder down the line?
So the things that I worry about, I'll put out there any patient with bleeding and pain, which sort of takes this conversation in a different direction, which I think we're not, but that is on the list of things that I'm often paying attention to. But focusing just back on bleeding, I'm often concerned about the patients who have persistent marked irregularity at 2 years or later out from their period, from menarche starting.
Yeah.
Also, patients who have very spaced out periods, so they are less often than 45 days apart, as well as patients who have abnormal bleeding where they are bleeding through, like I have patients who bleed for a month at a time. And for some of these patients, it's just spotting a month, but that's abnormal, as well as patients who have heavier flow. And all of those can be concerning for different types of menstrual disorders. One of the things that we're always looking at when it comes to menstrual disorders is, what is the differential diagnosis? What are the possible causes? For adolescents, the most common thing we're worried about is this concept of anovulation, of just not having the hormonal support that leads to like monthly egg production and the tight hormone control that leads to the uterus building, aligning, and shedding it. Many adolescents are anovulatory for a year or two or longer. And for those individuals, they can present with all kinds of different forms of abnormal bleeding. But the other thing we have to pay attention to is, what about the girls who just, their picture doesn't make sense in terms of the frequency of their bleeding, the volume of their bleeding. And we have to often, one of the tests we're getting is a transabdominal pelvic ultrasound. Now, for adolescents in our offices, we are only doing transabdominal ultrasounds. We are never doing transvaginal ultrasounds. We never need to do speculum exams, which I think is really helpful. Like, I can't tell you how many times moms are like getting their daughters ready to see me because they have no idea what I'm about to do. But it is none of those things. It is at most a transabdominal ultrasound to take a look and assess, make sure that there's no specific structural disorder of the uterus, which is highly unusual in adolescents and can start to be more common in the young adult population. But I can count on one or two hands the number of young people I've diagnosed with a fibroid. Like, that is extremely uncommon, or an endometrial polyp. These are benign growths of the uterus. Those are extraordinarily uncommon. But the bigger things that Dominder and I see are going to be the anovulatory bleeding, as well as the coagulation disorders. Those are the patients we're going to see the most of.
Yeah, thank you for that. And Dara, I want to go to you about the mental health, but very quick question for you, Dominder. If we don't address all of the things we're talking about, tell us what a few of the long-term complications are.
wanted to unmute myself first this time. Well, it doesn't even have to be very long. It takes a few cycles of heavy bleeding. Blood loss equals iron loss, of iron deficiency setting in. A patient who has had 7 to 10 days of heavy bleeding through and through can be iron deficient even if they're not anemic. And how I was saying 40% of adolescent females are iron deficient, they may not all be anemic. So certainly this is the longest, the biggest impact leading into iron deficiency or iron deficiency anemia, which can affect the quality of life for these young females. It can lead to poorer sports and activity participation. There's limitation to how comfortable they feel about going out when they're experiencing really heavy bleeding and are worried about needing to change every hour or so, as well as the effect that can come from long-standing iron deficiency that could affect learning and school performance, aside from the impact that comes from needing to go to multiple specialists or providers to go through a diagnosis and then requiring treatment that leads to school attendance loss as well. So many aspects that are avoidable by trying to recognize early and educating our patients.
Yeah, yeah. And I think that's a great segue to talking to you, Dara, about the mental health aspect of this. And I would love for you to give us your guidance on when we should be involving a mental health professional, because my impression is that young girls and women in general endure and are expected to endure quite a lot when it comes to menstruation before anyone says, wow, we should really involve a mental health professional here. So what are your thoughts?
Well, of course, I'm a biased party, so I'm going to say early and often. But in all seriousness, even just mentioning that these menstrual disorders can be associated with, distress, not even with like a full-on psychiatric disorder, but just that a mental health professional can be helpful in navigating these different disorders, can help normalize it. It can set the stage for if and when a young person does need more significant mental health down the line, they might be more open to it. Parents might be more on the lookout for warning signs. I would say you'd actually want to refer to like a mental health provider when the disorder is starting to interfere with their day-to-day life. So things that they were doing pre-morbidly or their peers or developmentally, like you would expect them to do, they're no longer doing. So their mood might be different. They're not wanting to go to school. They're not wanting to socialize. They're really, instead of integrating the disorder into their day-to-day life, the disorder is really running it. And then, of course, just thinking about like adolescence, it's such a significant period of time. People are individuating, they're gaining their sense of self. So to have anything that either you perceive yourself to be different or others perceive you to be different, you're just more at risk, because that's just sort of the opposite of what you wanted as an adolescent. So I think thinking about mental health with these disorders is definitely key.
Yeah, no, absolutely. I think I was going to pivot to PCOS, but I think let's address a couple of the questions that have come in the chat, because they pertain to what we've been talking about, and then we can go ahead and transition to PCOS, which I know that there's a lot of interest in talking about. So Dominder, I think this question is for you, and I think we can hopefully tackle these quickly so we have a ton of time to talk about PCOS. The person who put in this question in the chat says, I was taught middle schmersh, I hope I'm pronouncing it correctly, was mid-cycle pain. Does it always have to be accompanied by mid-cycle bleeding? Can you help us clarify that?
Right. So it is not frequently associated with mid-cycle bleeding. In fact, mid-cycle bleeding is a rather rare occurrence that happens more often in patients who may have an underlying bleeding tendency. So for hematology, we find that to be present in our patients, but it is a rather rare presentation. I can let Beth address this a little bit more if that's not absolutely correct, because my view is that of a hematologist.
I'm happy to add in. I mean, so technically middle schmerz is like the pain that may be felt at the time of ovulation.
Right.
And one of the things we already said is a lot of these girls are not always either ovulatory every month. However, at the time of ovulation, we do see a drop in some hormones before a rise in hormones. And the uterus of some individuals is exquisitely sensitive to that drop. And so some mid-cycle spotting or bleeding can be seen, but is not typical.
Thank you. The other question that came in has to do with how you assess, and really as you're getting your history right and trying to figure out if something is abnormal, wouldn't the frequency of changing the pad or tampon affect how heavy it is? How do you tease that out, Dominder?
Right. So one other consideration also is that young girls who are just starting to menstruate and are getting used to using these products want to be as clean and might even change things for hygienic purpose. So that's where I think discussion about why you're changing frequently, if you are, and showing a picture works very well here as well. But if anyone is telling you that they're going through more than 4 to 5 changes in a day, if it's beyond the first or second day, that alone is going a little towards the heavier side. It doesn't have to be towards the frequency of every 1 to 2 hours. But if it is as frequently as, say, every 2 or 3 hours, I would suggest asking how full these pads are, and are you doing it more for the hygiene purpose?
Yeah, which I always pause to ask when young girls tell me that they're changing so frequently. Is it because it's full or because you want to be super clean? And it's usually thankfully, because they really like to be clean. Now, one very interesting question. Beth, maybe I'll address this to you. How many tampons equals 1 pad? We usually ask about how many daily pads, but many girls are moving towards using tampons. How do you think about that?
That's a good question. I can't say that I equate them, but I just ask patients, how often are you changing your product? Is it a pad, a tampon, or both? Because some girls wear a pad plus either period underwear or a pad plus a tampon plus period underwear, or a tampon plus a pad for overflow. And to me, if someone is wearing a super or greater absorbency tampon and changing it, those should usually last a good 3 to 4 hours. And if they're changing it every 1 to 2 hours and it is soaked or they're having overflow already, to me, that is a sign of quite heavy bleeding.
Yeah. Dominder, would von Willebrand testing be feasible with our NYP clinics where labs are picked up at the end of the day?
So if you happen to have some site where they do like centrifugation of the tubes, then yes, because at least they're setting the tubes aside appropriately. But as long as they're picked up, I want to be very careful in advising this, because if it is a morning patient and tubes are being only picked up towards the end of the day, it might not be appropriate. But hopefully the reduction in the factor levels that we see can sort of get you to not worry so much, because say a normal level is anything above 50, can go as high as 150%. So if you're coming down from 100 to 65, you're not necessarily going to overdiagnose. But if you are at a borderline level of von Willebrand disease, technically refer already, and we make sure to repeat at least twice in reliable setting before diagnosing a patient. And that comes from guidelines for von Willebrand disease diagnosis. You have to have 2 reliable testing on different occasions, different timings of the cycles, to make a diagnosis of von Willebrand disease.
Yeah. So what I'm hearing is go ahead and send it. And then Depending on the interpretation, you can sort of worry a little bit about, when was it picked up? Is it borderline? And then repeating it. But it sounds like the answer is go ahead and send it, right?
Right.
Beth, very quick question for you, and then we're going to move on to talking about PCOS. We have a parent who wrote in that their 15-year-old daughter is having regular periods since they were 12. In the last 2 years, her cramping has become quite severe, and it seems to follow a pattern of pain at the start of her cycle. And then she will have severe cramps around day 3 or 4. Is this something that you would investigate further? So it sounds like new cramping,
Right.
new severe cramping at least after they had been pretty regular, and that the cramping continues into day 3 or 4. Is that something you would investigate?
So I think by the time someone comes to see me to evaluate menstrual pain, or what we call dysmenorrhea, we'll look at the pattern, we'll look at what sort of pain medication is being used, because most adolescents underdose pain medication and don't always take it effectively. And so making sure that they're taking enough pain medication within reason and safely to manage their symptoms is one of the first things. But if pain is persisting despite some use of pain medication, one of the things we'll obtain is a transabdominal ultrasound, looking for any structural abnormality or a cyst on the ovary, anything that could have changed. And if the ultrasound is normal and pain medication isn't enough to manage symptoms, we will then start to talk about the options for hormonal therapy to treat the menstrual discomfort.
Got it. Thank you for that. Let's talk about PCOS, and then we're going to tackle more questions. And guys, we may have to do a part 2 of this webinar because I think there's a lot of interest and a lot of questions coming in from our audience. So let's get to as much as we can. So Beth, what is PCOS?
So PCOS is a very heterogeneous disorder that affects about 15% of women. And it is the most common endocrine disorder that affects young and older women. It is characterized by some degree of menstrual irregularity and some degree of an androgen excess disorder, meaning that this often comes from the ovary. The ovaries are making some excess androgens that are either visible in the blood during blood testing, or we see evidence of that androgen excess affecting the skin, which commonly causes some increased body hair, may also cause some acne, may also cause some scalp hair thinning. And part of making the diagnosis of PCOS is also ruling out any other condition that can look like this. So it's important. So there's a whole slew of testing that we do to make sure that it isn't a thyroid disorder or something else that could also explain this constellation of symptoms. It's important to know that it's really a complex genetic trait. So there are influences that are both genetic and environmental that play into this. Mm-hmm. And the fact that it's a syndrome, there's multiple potential etiologies, and very variable clinical presentation. And not everyone's body has read the textbook on how to present with classic PCOS.
Right. Tell us very briefly. So first, what is the acronym? What does it stand for? The PCOS. And then also, what are the diagnostic criteria? And knowing that here at Columbia, we're very lucky to have a faculty member, Dr. Sharon Oberfield, who was part of the group that actually wrote updates to the diagnostic criteria. We get to brag about her. But what are those diagnostic criteria, and what does PCOS stand for, Beth?
So PCOS stands for polycystic ovarian or ovary syndrome. I always joke that I think it's a terribly named condition because everyone thinks of like, oh, I have all these cysts on my ovaries, and then they think these cysts cause pain, and that's not what this is referring to. The cysts of polycystic ovary syndrome are truly just lots of undeveloped eggs that are just sitting in the ovary quiescently and not necessarily causing pain. So I feel like the diagnosis always sends people astray a little, or that the name can be misleading. So the criteria to make the diagnosis are some menstrual irregularity that has no other condition causing it. And we either see evidence of elevated androgen levels in the blood. So we're looking specifically at the hormones, testosterone and free testosterone, and sometimes this androgen that comes from the adrenal glands called DHEAS, or evidence of androgen excess acting on the skin. So some women have normal androgen levels, but their skin is super sensitive to the androgens they're making, and so we see these skin symptoms. But we really need to see both of those, both menstrual irregularity and some form of elevated androgen in the blood or on the skin to make the diagnosis, and no other condition that can explain this presentation.
Yeah.
So as you explained, so Dr. Sharon Oberfield, who is a mentor of mine and a tremendous colleague, she was part of the group, the international group that rewrote the 2023 Diagnostic Guidelines for PCOS. And it is a exhaustive and long document. And one of the keys, and she and I spoke just the other day, just talking about PCOS in advance of this webinar, is there was a concern by the authors that people are making the diagnosis too early and too liberally. And we never want to give someone a diagnosis that might not be exact. So that's where this concept of menstrual irregularity can be seen until 8 years post menarche comes up. And that we really can't make the diagnosis of PCOS until 2 to 3 years after menarche, or the first menstrual cycle, because initially the pubertal changes that we see that are part of normal puberty include menstrual irregularity, include some acne, maybe some increased body hairs, etc. So a lot of normal puberty can also look like PCOS, so we don't want to overdiagnose those individuals. So there's this new label or called at risk for PCOS, which is truly what we're calling patients at 2 to 3 years out from their first period who have the symptoms that may look like PCOS, but we don't want to give a diagnosis too early. And so this is what we're using this is the diagnostic phrase that we're using, which doesn't pigeonhole patients the way we may have in the past. However, it doesn't mean patients can't get treated. We will still treat abnormal bleeding and menstrual irregularities and skin issues and all the other parts. So this I think is one of the most important parts of this consensus, and that's one of the things Dr. Oberfield really wanted me to emphasize to the group.
Yeah. And we so appreciate you and her for bringing this nuance, right? Now, for the parents, and I think we have quite a few parents who are joining us this evening, how can they help as, this diagnosis is being considered? And it's a diagnosis that takes time to make, right? How can they help?
So I think one of the most important things to do is to keep a menstrual calendar. And what that means is, and I really think it's on the adolescents' shoulders to document either on their phone, there's a ton of great apps out there, or on paper, or in a notes page in their phone, when they do get their period, when it begins, when it ends, and keep a list. Because we don't really rely on mental acuity for these details. And it's so helpful to sort of pay attention to patterns. Yeah. I can't tell you how many times a mom and daughter are sitting in my office, or a dad and a daughter are sitting in my office, and they're not on the same page about information. We don't have really data written down, and it's really hard to understand, is there truly menstrual irregularity or not? So I think using a menstrual calendar for documentation is important. And we know, and Dominder sees this, and Dara sees this too, menstrual disorders, paying attention to the timing and tempo of puberty and menstruation is important as a marker of health. And one of the first signs that a kid is really stressed is their period can go from being very normal to very irregular. And that could be a sign of tremendous, school-based, other psychologic-based stress, et cetera. So I think a menstrual calendar is probably one of the most important things.
I think it's we just can't emphasize that enough, right? Really, for me as a primary care clinician as well, gosh, it's so much easier when we come with that information. So really, Beth, broadly speaking, and we have a lot of questions that are coming in, and we'll definitely tackle those in just a minute. But broadly speaking, what are the treatment options for PCOS once the diagnosis is made?
And one thing I forgot to mention, if it's okay, just to go backwards, is there's this other part of the diagnostic criteria that is no longer considered for adolescents, which is the transabdominal ultrasound. So that was the one thing I just realized I forgot to mention, is that that was always part of certain diagnostic criteria, but because it is so hard to do ultrasounds and see the ovaries well in adolescents, the ultrasound, while it's still a diagnostic criteria for adults, it is not on the algorithm for the diagnosis of adolescents. So that being said, in terms of treatment for PCOS, we're really looking at managing the menstrual disorders, which is one component. We're managing sort of the cosmetic skin issues, which is for some girls, increased body hair, acne, and possibly some scalp hair thinning. And then also the metabolism component, which about 50% of girls with PCOS are going to have have metabolic dysfunction as part of their PCOS presentation. So we're managing the menstrual disorders usually with some form of hormonal therapy. Most common is going to be a birth control pill, but we also have pills that contain both estrogen and progesterone, as well as some that contain just progesterone. There may be some individuals out there who can't take an estrogen-containing therapy, but we're using these hormonal therapies, both pills, patches, IUDs, lots of different options for protecting the uterus from abnormal cell growth over long term and the risk of abnormal bleeding, protecting the girls from anemia, and managing the menstrual disorder part. We're using other medications, both referrals to dermatology for skin issues, as well as some other hormone blockers to block androgen effect on the skin to treat some of the skin and hair issues. And then using different medications to manage metabolism, which commonly includes metformin, which we think of as being used to treat diabetes, but it is also very effective for the metabolic dysfunction of PCOS. And a lot of adolescents who are carrying more excess weight are doing well with actually some of the GLP-1 receptor blockers, which are like the Ozempics, et cetera, is something newer in the adolescent world. So that there is a whole host, and have some patients who need one of those therapies and some patients who need 2 or 3, and we individualize our care to the patient and their concerns.
Yeah, so many options. As you're talking, again, we're just reminded of the options that we have, and we're very lucky to have, and that things have come this far. We mentioned complications earlier as we were talking about menstrual disorders. For PCOS, Beth, very quickly, what are the long-term implications if we don't treat, if we don't address the symptoms, if we don't make the diagnosis?
So the long-term implications, there's a number of things. We know that, this is there's some genetic basis to this. And this condition is associated with long-term increased risk of cardiovascular disorders, including high blood pressure, high cholesterol, prediabetes, diabetes, obesity. There are definite mental health components to this. We see a higher rate of mental health disorders, depression, anxiety, body image issues in patients with PCOS. And what I also see in my fertility practice is infertility. And I see patients where this wasn't, this may or may not have been diagnosed when they were PCOS when they were younger, and they come to see me also trying to conceive. So, and then lastly, something I just mentioned is the risk of uterine abnormalities. And if menstrual disorders go untreated, and the uterus needs to see a balance of estrogen and progesterone each month, which happens with ovulatory and menstrual cycles, or if we're giving contraceptive therapies that contain progesterone, those protect the uterus. If we don't protect the uterus, there is a long-term, over years risk of precancerous lesions of the uterus and uterine cancer. And to me, that's one of the scariest things that we need to protect these young girls from.
Absolutely. Absolutely. Where can, Beth, general providers, community clinicians who are on the call tonight, send their patients if they're looking for help? This is, as we said, sometimes a tricky diagnosis to make. We're very fortunate to have you here at Columbia, right? And a team of endocrinologists as well who can help us with this diagnosis. But where can they send their patients?
So I'm fortunate to work closely with providers in adolescent medicine as well as pediatric endocrinology and myself. And we all come at this with sort of different expertise, but with sort of a unified desire to care for these individuals. I tend to see more the menstrual disorders or concerns about PCOS leading to someone come to see me. The endocrine team might see patients with more of the metabolic disorders, obesity, insulin resistance, et cetera, as the start of someone's PCOS journey. So I think we are all capable and willing to start this evaluation, and we send patients back and forth as needed, but all three of those groups, both pediatric adolescent gynecology, adolescent medicine, and pediatric endocrinology, all have the expertise to start this evaluation and to lean on each other for more comprehensive care.
Amazing. Dara, let's talk mental health. I want to ask you, of course, specifically about the mental health toll of PCOS, and perhaps a bit of context to introduce here is that many women who have PCOS go undiagnosed for years. And I believe you mentioned that, Beth, it takes time. What is the toll, Dara, of not having a diagnosis for a while? And what is the toll on young women's mental health once they do have the diagnosis? I can't hear you.
Oh, can you hear me now?
I can hear you. Yeah.
Yeah, I think Beth just outlined a lot of the mental health implications of having this disorder, or being at risk for it. I think many of the symptoms associated with PCOS are things that are really stigmatized in Western society. So then when adolescents are starting to have them or develop them, like increased body hair, higher BMI, irregular periods or not having their periods, they're just going to feel different than their peers. And whether or not the peers perceive them that way, they're just going to probably be set up to be more at risk for mental health, in addition to the higher rates of anxiety and depression that are seen with PCOS. Usually when it takes a long time to get a diagnosis, people's minds sort of go to the worst case scenario. So they're probably imagining something even worse than what it probably really is. So that could suggest some like anxiety that's been going on for a while and building up. And then once they get the diagnosis, I would imagine at times it's just hard to really believe that it truly is a diagnosis. They might have questions about like, why did it take so long to get here? Why didn't the first 4 people I saw figure this out? And I think from tonight, we sort of know why, but if you're just, if you're an adolescent, if you're a teenager, to have that insight isn't as normal. So I think that can lead to confusion and probably wondering too, whether or not this truly is a diagnosis. Are they getting the right treatment? Are more things to come that they don't realize?
Yeah. It's a big deal. It's a big deal. And involving people like you early is so important. We have a ton of questions that have come in. Let's tackle as many of them as we can. I do want to tackle first a question that came in very early this evening from a parent. So here's what they're telling us. And Beth, maybe I'll address this to you. Our 14-year-old daughter was just diagnosed with PCOS. She hasn't gotten her period yet. Her testosterone is 57. Her fasting insulin is 18.8. Her fasting glucose is 96. She has a hemoglobin A1C of 5.5. Her pelvic ultrasound was normal, but it shows that her ovaries are receiving hormonal stimulation. They're very overwhelmed. They spoke to a nutritionist once. They're muddling through this while trying to get their 14-year-old to cut out carbs and sugar and exercise. And I think later on, they also mentioned that they were told that their teen is becoming insulin resistant. How do you, it's tough because we're not seeing this teen, we're not meeting this teen, we're not, unfortunately, their medical provider with all of the information, but how do you advise parents on starting to sort through all of this? Is this an accurate diagnosis? It sounds like that's what some of the concern is.
So I think this young person is probably in that maybe at risk sort of category, if that. I think we have to look at the timing and tempo of puberty, because we definitely get concerned if someone has not had their first period and they are 3 years from when they started breast development. So that's like one of the markers that we look at. And for individuals such as this, it's hard to just look at random hormones and understand what's going on. So we typically, looking at the whole picture, might use some progesterone pills to bring on a first period, start to see, does that spur things on? But it's hard to piece out if this is like an ovarian hormone disorder or metabolism-driven disorder or both, because we know that the metabolism component can make hormone labs also look off. So again, this picture there's some complexity. We don't normally get diagnosed like primary amenorrhea or lack of a first period until typically 15. But I think having specialist care to evaluate this picture, to me would make a lot of sense.
Yes, so definitely seeing a specialist to help you sort through all of this and knowing that it takes time, but we really appreciate the question. There's a couple of questions also for you, Beth, that have come in about what are the initial labs that you would order for a workup of PCOS, because there are conflicting recommendations about checking DHEAS. So and different testosterone and free testosterone versus not. What are your recommendations?
So when I'm dealing with menstrual irregularities and question PCOS, I mean, one of the set of tests I'm drawing are the reproductive hormones, because I never want to miss someone who has like ovarian insufficiency as part of that presentation. So I'm checking FSH, LH, estradiol, and progesterone just once to look at that picture. You know, depending on history, pregnancy test is one of the other things to think about. And then we're checking thyroid with a TSH, we're checking prolactin and total and free testosterone. Now, you need to find a lab that actually has reliable testosterone assays. And I think it's I know what it says in our, but I think I have it written down. I will come back to that. But basically that we need reliable testosterone assays to check. And then I always check DHEAS, because in 20% of females, we see it's the adrenal androgens that are elevated, but not the ovarian androgens, which are mostly total and free testosterone.
Yeah. Thank you for that. It is a lot, of maybe what we can do, Beth, is in the recap of the webinar, send the link to the latest recommendations so people can sort of reference those, because unless you're already very familiar or you were writing that down very quickly, it's tough to keep track. So we can definitely send that to everyone who joined or register this evening. Beth, you made the comments about 8 years after menarche, sometimes seeing irregularities, and someone sent us a question: should we wait to diagnose PCOS until after 8 years? After 8 years after menarche. So I wonder if you can clarify that a little bit.
So I think, again, this all came out with this 2023 sort of this international consensus that we can see menstrual irregularity up till 8 years out from menarche. It doesn't mean that we wait to diagnose this at risk of PCOS cohort, which likely will have symptoms within 2 to 3 years from menarche. I think it's just recognizing that we can see persistent menstrual irregularities for up to 8 years for some individuals. To me, again, I hadn't read that before this guideline came out either. So I do think that that's a bit more on the high side, on the extreme side of duration. And the important thing is we're not going to deny care and treatment to manage symptoms, be it menstrual irregularity, metabolism issues, etc. But we're going to recognize that there can be some menstrual irregularity that, that can be considered normal still in those years.
Yeah. Thank you for that clarification. And it's, again, like it's a menstrual irregularity, but it's a lot of other things that you're taking into account. So it's not that alone. Now, as we were talking about earlier, for the parent that sent us that question, the clarifying question was, which specialist should they see? And I think the answer then is endocrinologist or pediatric and adolescent gynecologist like you, Beth, to help sort of really narrow down what the diagnosis is. Other questions that have come in, and I'm having a hard time keeping up because there's a lot, which is great. And it tells me that we need to do a part 2 of this. So let me see. There's one very interesting question that came in. What is the physiologic / biochemical abnormality that causes obesity and PCOS, Beth?
So again, this is about 50% of the individuals, but it is this concept of insulin resistance where as part of PCOS, many women are less sensitive to the insulin that they make. And so their body makes more and more insulin. And that leads to sort of an inefficient metabolism and leads to often weight gain. And that's a very simplistic way of thinking about it. But it's really driven by this hyperinsulin, like high insulin levels, making metabolism dysfunctional.
Yeah.
And thus that can lead to obesity.
Yeah, and I think that answers another question that had come in about lean PCOS. And I know that there was more nuance to this question, and I apologize because we're out of time, but not every child who is diagnosed or teenager or young woman who is diagnosed with or person who menstruates with PCOS is obese, right? Or has a diagnosis of obesity. So super important to keep that in mind. We have unfortunately run out of time. We are so grateful to our panelists who joined us this evening. I hope this was helpful to everyone who took time out of their evening to learn with us and to ask us questions as well. We will be sending a recap email after tonight. It'll have the recording from the webinar. We'll also send the updated guidelines for diagnosing PCOS because there were so many questions about that this evening. We'll send information on how to refer to Dominder or to Beth and our specialists here at Columbia. And we hope that you will sign up for the CME meeting happening in December. We won't have a webinar in December because the CME meeting will be packed with so much amazing information. And then we will see you again for one of these webinars in January, and we will announce what the topic will be shortly. Follow us on social to find out first. And then we hope to see you soon and that everyone has a wonderful holiday season. Thank you to our panelists for joining us, and we'll see you next time.